Good evening and a warm welcome for this question and answer session on the cardiorespiratory complications and the management related to COVID-19. So it's my pleasure to invite you for this session. Uh, Before we begin, we have heard a lot about this pandemic going on. So I'll just give you a brief about what this pandemic and how it is looking. So we all know what is coronavirus. It is actually going around right now. So it's a family of viruses affecting the respiratory tract. It can range from diseases from common cold to pneumonia. Usually it is found in wild animals or bats. It is transmitted to humans directly via other animals. And in humans, we know it is somehow transmitted via respiratory droplets. That is the latest understanding which we have. So this is how it has come through us. The 2019, we still don't know how the exact mechanism has happened. Uh, we know a few details about the virus on which the vaccines are being developed, the spike protein, the envelope protein, the membrane proteins, the RNA. Uh, this is what a chronology of events which have actually started. We had the first case somewhere in December 31st December, China alerts WHO. And from that day till 20th of in the March, we had India reporting its first case. And we know the situation today where we have already crossed 1 million cases. So coronavirus or the COVID-19 can present with varying symptoms. It can present with shortness of breath, high fever, vomiting, pneumonia, even coughing and diarrhea in some cases. So that was the situation till now. We know as the pandemic has progressed, we have found that the diagnosis may be difficult. It may have a varying impact. There can be atypical presentations. It could be as simple as cardiac complications. There would be residual symptoms even in asymptomatic patients, where we would not know that the respiratory system has been compromised. There has been death which has been reported in certain populations, example diabetics or hypertensives. More lately, we have also seen pediatric complications which have actually come to fore. So to understand more and to get more details about this from experts, we have two eminent speakers for the evening. So our first speaker is Dr. Rakesh Varamasar. He is currently the Director General of Health Services and Professor and Chief Cardiologist of Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi. In his honors, he is a physician to the Prime Minister of India, physician to the Chief Justice of India, physician to the Governor of Punjab. He is a 2 times Joint Secretary of CSI India. He is also the Secretary of Cardiology Branch, Delhi. He is also a fellow at Texas Heart Institute and the Institute of Cardiology, Phoenix, USA. He is a gold medalist as an MD and DM and was part of the basketball team as well. Our next speaker for the evening is another eminent personality. He is Dr. Anand Ohan. He is currently the professor and the head of pulmonary critical care and sleep medicine at AIMS. He is the recipient of UK Commonwealth Fellowship in Chest Medicine and Interventional Pulmonology. He's he's been a part. He's currently the chief investigator and the co-investigator of several international collaborative and extramural projects funded by various bodies. He has over 200 international and national publications and peer-reviewed journals. He is also a fellow of Royal College of Physicians, London, the National Academy of Medical Sciences, and European Respiratory Society. He has numerous awards to his credit. So, welcome, sir. We will begin this session, and we would request our audience to also put a few questions which they have in their chat box. Right. So, sir, the first question is for Dr. Verma, sir. Sir, we have heard a lot about COVID now, and it is presenting in atypical symptoms like cardiac complications. Sir, could you please enlighten or highlight a few things for us from this point of view, sir?
See, among the patients of COVID-19 is a serious pandemic, and the disease is very communicable. So a lot of physicians, doctors, paramedics are very scared. And those who did not take due precaution in the beginning suffered. And we remember more than 150 very senior doctors have died. So knowledge about cardiology and COVID is very preliminary and very sketchy. All that we know is this virus affects the myocytes by direct penetration, by utilization of AC2 receptors. It injures the myocyte, causing myocarditis. It does cause myocardial infarction. It does cause a congestive cardiac failure. And all this could be very fatal. Some of the drugs and the disease itself cause serious cardiac arrhythmias and which are the cause of the deaths in a lot of situations. So cardiology is one of the situations where COVID is a cause of mortality for a large number of patients and which is causing effect to the total scenario. You will be surprised to know of the total deaths, which range about 4 to 5% in various in general across the world. If somebody has got uh, pre-existing cardiac disease, the death goes up to 11%. And those who are having diabetes mellitus, the mortality chance goes from 8.5 to 9.5%. While those who are having other comorbid situations are being hardly affected. So this disease and cardiology have got very bad relationship insofar as cardiology is concerned, insofar as this situation is concerned. So this is very panic situation for all of us. So this disease can itself cause a lot of cardiological symptoms, a lot of cardiological complications, a lot of cardiological deaths are occurring because of the COVID infestation and infection.
Right, sir. Thank you very much. We'll come back to the cardiology sessions again. So, meanwhile, I have a question for Mohan, sir. Sir, we have seen COVID presenting in various formats, like even asymptomatic individuals to even to maybe who are having severe diseases. So, could you just give us a general brief idea about how COVID symptoms usually progresses in patients?
Better
How do they occur?
Okay. So, like you already said and already has been highlighted that approximately 80 to 85% of the patients have mild symptoms. In fact, I would say up to even one third or maybe even more in some series. The series which we have recently published, about 44% of our patients were actually asymptomatic. So that's a pretty high number, but so it just means a significant proportion remain asymptomatic in spite of being microbiologically positive. The remaining people also have, most of them have very mild symptoms. These symptoms are mostly fever. Fever may be again ranging from the mild to moderate, rarely goes very high, and usually it finishes off in 3 to 4 days. Or they may have a dry cough. The dry cough is the most distressing symptom. Some cases go on to have some shortness of breath, which may be transient for a few days, or they may be having sore throat. Some of them have upper respiratory symptoms like a runny nose or uh, burning of the eyes, sneezing, and some of them may have other atypical symptoms like body aches, fatigue, headaches, myalgia. These are common symptoms because basically it's a viral disease. So the symptoms of myalgia, weakness, fatigue are all symptoms of a general viral illness, which is often there, and it often remains for quite some time. So these are the main symptoms, the classic symptoms. Then there are certain other atypical symptoms that have been seen. For example, loss of taste, loss of smell. Then there may be GI symptoms. For example, there may be diarrheas, and then there may be other atypical symptoms. For example, then the heart symptoms may be there. Rarely patients with pre-existing heart disease may present with exacerbation of the heart illness, heart failure, maybe transient arrhythmia. So all these are some atypical symptoms. So as far as the progression is concerned, again 80 to 85% of them recover without any significant problems and without even any specific therapy, only with supportive care over a few days. Then there are about 10 to 15% patients who require some kind of support, which is in the mostly in the form of oxygen therapy. So that oxygen is given, or maybe some of them require NIV therapy, that is in a high dependency unit. About 5 to 10% of the patient, or 5 to 7% of the patient may require monitoring in the ICU with NIV therapy, high flow nasal oxygen therapy, or other whatever supportive therapies is required. One other atypical symptom that we saw was, it's not actually a symptom, but goes on to develop a thrombotic phenomenon. So we have seen patients with developing thrombosis, which may be more in the peripheral vessels, or sometimes even mild cases. Some cases of stroke have been observed. Some cases of heart disease have been observed. So thrombotic episodes are there because of microthrombi mostly. So these are some things. And those who go on to develop ICU like situation, then out of that again 2 to 3% or 5% require mechanical ventilation and support. And out of that also some of them, many of them recover, and then some of them there is a small amount of mortality associated with this as well. So that is broadly how it all pans out.
Right, sir. Thank you. But just one more question in addition to that. From exposure to how many days would the symptoms actually pan out? Say, if a person is exposed, how much time would you expect that the symptoms would actually occur? Say, 4 days, 1 week, or till how many has been the average which you have seen, sir?
The incubation period is widely variable. So it may last anywhere. It may start, so from the time of exposure, it may development of symptoms may start as early as 3 to 4 days, or it may start, even we have seen starting up to 15 to 17 days after the so-called exposure had occurred. So it's a very wide variability in the exposure. On an average, anywhere between 5 to 7, 5 to 8 days can be taken as the mean of all this. But again, there is a very wide range of this. And as we have already seen, a large proportion are actually asymptomatic. So they don't develop symptoms at all. So there is no question of any incubation period in them. They are just picked up. Suppose somebody or a contact, a family member of a patient is tested and he turns out to be positive, but he is not symptomatic at all. So in these things, the question of incubation period does not arise. So that is how it is.
Right, sir. Thank you. Thank you so much, sir, for giving us this perspective. So my next question is to Dr. Verma, sir. Sir, we just heard from Dr. Mohan right now that he said that there has been incidents of VTs. There has been people who have actually reported with microthromboemboli. Sir, could you please tell us how this thing is actually diagnosed, or what are the tests which we need to do? How do we go forth to understand this?
Ashish, as you are very correctly pointed out, in this pandemic is very new. The magnitude of the problem, the severity of the problem is unprecedented. They have been absolutely banned and barred on doing any pathological or autopsy studies, except for small serum tests, distant data we have been doing in the live patients for diagnostic and therapeutic purposes. So exact pathophysiological mechanism which is causing a death is still a matter of speculation, conjectures, and hypotheses. Nobody can say till to date what is the exact cause of death. Unfortunately, all the pathway of the death, endpoint of all the deaths has been ARDS and multi-system failures. But as I said earlier in this part, none of us is allowed to do a pathological specimen, pathological studies, postmortem studies. One or two doctors take cases have done without the permission of the government or without permission of regulatory, but they cannot be relied for good. However, like in the beginning of this COVID-19 epidemic, everybody started saying that a possibly high pressure oxygenation by heavy duty ventilation and ventilators could make a huge difference. But subsequently, by the end of the May, this speculation hypothesis also found its way to exit. Now there's nobody saying that we have to depend. Then second hypothesis started coming was is patients are dying because of deep vein thrombosis, pulmonary embolism also, but that is all a very, very limited hypothesis or conjecture or speculation. And a lot of things came in controversial. But overall, as a treatment therapeutic part, the government of India and the senior centers who have been performing this, have been advocating use of low molecular weight heparin in the patients who are hospitalized, not as an OPD treatment. This webinar is very important, but I don't want to convey a message which could be carried in the wrong way. See, a treatment, as Dr. Professor Anand Ohan has very brilliantly said, only about 90% patients would not require any treatment except small antipyretic medicines, that could be form of calpol or other things, or aspirin. And only about 5 to 10% patients will require hospitalization. Out of the 5 to 10, only about 2 to 3% will require high intensive ICU care. So these all treatments are restricted for those 5 to 10% patients. Majority of the OPD patients could be treated by simple symptomatic treatment, and they resist and fight this virus. However, in those selected patients who are hospitalized, low molecular weight heparin is recommended in zero point 0.4 or 0.6 milligram twice a day, depending on body weight. Exact calculation is not there, but this has been found to be very, very useful. A lot of cardiology patients, since they are already on aspirin, we continue the aspirin or sometimes have increased the dose of aspirin in treatment of this COVID along with deep vein thrombosis kind of situations. A lot of situations came sometime in mid-April that people are dying because of the secondary pneumonias or uh, gram-negative pneumonias, other pneumonias. But again, the diagnostic facilities are also restricted. If a patient COVID goes for a CT scan, now for next 7 days, you cannot use the CT machine for non-COVID patients. And COVID centers themselves do not have the CT machines. Although government has done a lot for putting on the ventilators, X-ray machines, but you must remember, this is a situation which is unprecedented. And while treating a COVID patient, we have to protect our non-COVID patients, which are having a very heavy toll because of this dispension in the situation and the society. I hope this answers your query.
Right, sir. This answers a part of the query. We also wanted to know what are the tests which you would probably advise for patients to diagnose such patients on VTE, sir. Any specific tests which you would advise, sir?
See, a lot of tests have been recommended, but hospitals, laboratories are very, very skeptical and cautious about doing any test on a suspected patient of COVID because they feel their systems will fall apart. So whatever medicine we are giving, even for treatment of deep vein thrombosis, is an empirical. I'll request Dr. Mohan to answer this query.
Right, sir. So this next query is also for you for the diagnosis, sir.
Dr. Mohan to answer this second
Right,
query.
sir. So
Yeah. So basically, what usually we do is for all patients who are hospitalized, like already has been mentioned, our protocol is to start prophylactic doses of low molecular weight heparin in all patients who require hospitalization. Hospitalization means at least those who have got moderate illness, okay, not the mild illness. So anybody with moderate illness, as per definition of the Ministry of Health and the WHO, and anything beyond, they all get prophylactic low molecular weight heparin. That is one. So whenever suspected, so we don't do we don't do a screening, DVT screening for all, but yes, wherever suspected, wherever the patient is not responding to the standard measures that we take to the oxygen, or suppose he deteriorates, or there is any other situation which leads us to clinically suspected pulmonary and thromboembolism, then we first do a DVT screen and to exclude any kind of deep vein thrombosis in the limbs. And if anything else has to be done, then we go for a CT scan. But again, doing a CT scan in patients is not very easy. So there are practical problems even in hospitals. So in our setup, what we have done in our center, we reserved 1 day per week for a CT scan of our COVID patients. So we used to keep all patients who required a CT scan for that day, and that 1 day, all of them used to go for a CT scan. Then the machine used to be sanitized for use on a Monday. So or from Saturday to, so that was how it was. And again, if required, then one can use the ultrasound machine to do the bedside echo also. So of course you have to have proper infection control measures when you do all these things. The person doing it has to be in protective gear. The machine has to be, well sanitized before and after, or the probe has to be sanitized. So all these precautions have to be taken. Hence we cannot do this as a general rule for everybody, but only for selected patients in whom we are really strongly suspecting. Of course, one more important test here would be the D dimer. So we do the inflammatory markers, we do the fibrinogen, the D dimer, the LDH, the IL-6 levels, and the CRP levels in almost all our patients. So this gradually, this all setup we got into our laboratory. Not immediately, but gradually we got all these things available. If the D dimer is high, patient is supposed desaturating in spite of oxygen, not maintaining saturation, or is becoming more dyspneic. These are probably the indications to rule out a significant DVT or a pulmonary thromboembolism.
Ashish, actually, you got the full answer. So these tests are for very, very selected patients in very specialized setup. So we don't recommend this to be done on each and every
on
patient.
each and every patient, right?
Otherwise, the system gets spoiled or affected over that corporate group of things, and the patients without COVID are being affected.
Right, sir. So my next question also comes to you, sir, Verma, sir. So we have heard that there is a elevated troponin levels which have been found in patients of COVID, and some patients do present with myocarditis or something like that. So we have a question which has come to us from the audience. They would like to know, how do you distinguish between an acute MI versus a patient who has presented with a COVID-related troponin elevation, sir?
See, the query is very, very pertinent and very correct query. Understand the situation. We have to save the life of the patient, irrespective of the pathway which is taking him towards the mortality or morbidity. So here, the moment you get a troponin high levels, it is indicative that the myocardium is being affected, is being inflected, is under strain and is getting injured. So we have to protect, save and preserve as much of myocardium as we can do with doing all extensive things. Distinguishing at this juncture whether patient has acute myocardial infarction because of the like symptoms or signs because of COVID or per se because of atherosclerotic is not situational thing. Because in patients who have got COVID and pre-existing cardiac problems, it could be a plaque rupture is seen very high level, but this is all surmises and hypothesis because autopsy, biopsy studies are not there. It could also cause distinction of plaque. The COVID itself can cause myocardial infarction. As Dr. Professor Mohan very kindly suggested, it could cause arrhythmias. Even the drugs which are being recommended, like hydroquinone, was also going to change the pH of the cells. It was causing long QT symptoms. It was causing arrhythmias. So here the question is not whether patients have got high troponin only because of the cytokine storm or only because of the myocarditis, but please, aim is to save the life of the patient. Consider all patients with troponin high to have myocardial infection, infarction, myocarditis, and start treating them. You cannot give them patient the streptokinase, urokinase, other things. You have to maintain his, as Dr. Mohan said, you have to maintain his oxygen levels, maintain his blood pressure levels, see if there's any existent disease, treat them, and try to save and protect the patient. So any level high troponin, high levels is an alarm for you. As Dr. Mohan Center said, they are using a separate echocardiogram machine or bedside also to diagnose that. If you got regional wall abnormalities, whether it's because of the atherosclerotic injury or COVID injury, cannot be distinguished at this stage.
Right, sir. Thank you very much, sir. So, since we are at the stage of diagnosis, our next question comes to Dr. Mohan, sir. Sir, what would be the ideal way to go forth for diagnosis? Would you prefer a RT-PCR, a CT scan, or in the current situation where we are right now, would only a surveillance test be enough, sir, or an antibody test?
Well, antibody tests are not meant for diagnosis. So, like you said, they are meant for surveillance. So, for diagnosis, they are not there. As far as diagnosis is concerned, right now we have a couple of tools at our disposal. RT-PCR, of course, it is by far what you can call as the gold standard as of now. So even though it is not 100% sensitive, but still out of all these, whatever we have, it is one of the best ones. So with the sensitivity of somewhere around 70 to 85%, it is by far the best. So that is the traditional gold standard as of now, which has to be done with a proper throat swab or a oropharyngeal swab. Ideally, that test is also has to be performed very nicely. So there are a lot of inter-observer or say the person who takes the sample, how he takes the sample determines the quality of the result also. That is very important. The method of taking the sample, the proper storage, proper transport, and then comes the last part is the RT-PCR. So this whole process is there. The other test that we have available with us is the rapid antigen testing, which has now come up. So rapid antigen test also has been tried at several parts of the country, including in Delhi, and that has shown reasonably promising results. Again, between 50 to 70% of sensitivity is there. So basically, it just means if you do a rapid antigen testing on a person, if he is positive, then you can be pretty well sure that he is positive. But if the test is negative, then you cannot rule out a COVID disease. That means if you really suspect and if the rapid antigen test is negative, you still need to go in for a RT-PCR to confirm the diagnosis. That is one. Similarly, the rapid antigen test is why not really meant for use or advocated for asymptomatic individuals. The chance of it getting positive is highest when the person is actually symptomatic. So it is not really a tool for screening. All right. Otherwise, you will end up by having a large number of false negative results. You will just keep on doing the test and getting negative results. That is one. The third possible tool that we have is the the TrueNat test. The TrueNat test is something very similar to the gene expert test for tuberculosis, that is a CB-NAT cartridge-based nucleic acid amplification test. So this is the on a TrueNat platform machine, which is a Indian-made machine, and now being now advocated and distributed widely throughout the India by means of the National Tuberculosis Control and Eradication Program. So that is now being used for the coronavirus detection as well. That also has a reasonably good sensitivity of around 60 to 70%, and that is why we are using this as a rapid point of care test, especially when you need in emergency situations to take some decision. For example, you have to perform some emergency surgery, some emergency procedure, and you really don't have time to wait for RT-PCR, which can take up to 12 hours, and even in some parts of the country, even 2 to 3 days actually. So in these situations, the rapid antigen test and the TrueNat test are two rapid point of care tests with a reasonably good sensitivity and very high specificity, which can be used. So these are the molecular tools that we have. And as far as the CT scan that you said, again, these are all complementary tools. CT scan, if positive, there are some very typical findings on a CT scan of ground glass appearance or a peripheral basal or a middle peripheral consolidation type appearance. So these are some typical findings of a COVID infection in this scenario. So, but again, if it is negative, it doesn't rule out. If it is positive, it points strongly towards COVID, but it can be positive in many other infections, including viral infections as well. So we have to take the entire picture into consideration: the clinical symptom, the setting of the patient, the microbiology, and the radiology. All of them together have to be taken into consideration. All of them need not be positive at any given point of time, but we have to take a conscious decision of the same.
Right, sir. Thank you very much for this elaborate answer. The next question is for Dr. Verma, sir. So this comes from the audience. They would like to know, is there any role of heparin? And how long can a low molecular weight heparin be given, sir?
See, that situation is that we are not using heparin per se, because as we mentioned in the talk about 10 minutes back, that this is more of an empirical treatment, as a more of a prophylactic treatment, more of a treatment without running a lot of diagnostic tests, because treating a COVID patient is very, very dangerous for the physician, paramedics, nurses, and everybody. And as you remember, a lot of very senior doctors have died across the globe, and India is not left alone. One of our colleague doctors from Delhi, who was treating COVID patients, ultimately lost his life despite all therapeutic measures. So we have to maintain a very safe distance and not running unnecessary or avoidable or empirical tests. So in this situation, as we mentioned, low molecular heparin 0.04 or 0.06 is given for duration while patient is hospitalized and is not recommended after patient is discharged.
Thank you, sir. Thank you very much. Since we are on this topic and we are continuing with this, we had a raging controversy which was going on with the use of ARBs and ACE inhibitors, sir. Sir, could you point us a few pointers for our audience on this?
This is again a very relevant and pertinent question. I'm very happy that you raised this question. See, in the beginning of our conversation today, I mentioned that this virus enters from the three entry points, that is nostrils, mouth, or eyes. That's why you recommend covering of the nostrils and the mouth by a good quality mask whenever is required. Do not hesitate in using that. And once it reaches the respiratory system, it is the ACE2 receptors which modulates and through which the virus enters the system. And that is why there's a huge controversy, huge debate, whether to use these inhibitors or not, whether you can use these inhibitors or receptor inhibitors or not. As a matter of fact, some studies are saying that they are beneficial, others have got contrary result. And since we, as of today, without doing more diagnostic and pathological studies, it cannot be determined how and when. I personally am not recommending use of ACE inhibitors or ARBs in freshly found COVID patients. But if patient is pre-existing on these ACE inhibitors or ARBs, I am not discontinuing. In case they change the symptoms, profile is changed, then we may consider. But a settled patient, a patient who's already controlled on ACE inhibitors or ARBs and develops COVID without any change of the much profile, I will recommend not to change. But if a fresh patient is diagnosed during COVID era with hypertension, please do not start with ACE inhibitors or ARBs. You can use other modalities, and preferably beta blockers would also be avoided because of the myocarditis situation.
Right,
That
sir.
solves it.
Right, sir. Thank you very much. So our next question comes for Dr. Mohan, sir. So this question is many patients remain hypoxic and NIV dependent for longer periods. Even the general condition improves if there's even a CSR is chest X-ray is okay. What could be the reason for that, sir?
Well, so now as we are having a little more experience of more and more patients, so out of we are seeing a number of patients, not a number, a small number of patients who after, even after the symptoms, other symptoms have resolved, but they still do keep, being hypoxic and maybe require some kind of oxygen. So there are two type of things over here. One is a situation in which a person offhand is hypoxic, but he will not be very much symptomatic. So the reason could for this could be two. The situation in which maybe the pulse oximeter, the saturation probe that we are using for measurement of the saturation, whether we that is has its own limitations as well. As long as the saturation is normal or slightly on the normal higher level, then it is okay. But as soon as the saturation starts falling, say below 85 or something like that, then it is not that reliable to tell us the actual oxygenation status of the patient. So that is one. The second thing could be a person may have kind of acclimatized to his oxygen level to his hypoxia level, in the sense that he may not be exerting, so he's comfortable. So he looks comfortable, but he remains hypoxic. And another reason could be that the symptoms of dyspnea and breathlessness come from receptors in the brain. So hypoxia, to try and affect the brain and reset the central receptors of hypoxia and the brain may take some time. So sometimes so these are the situations which are known as happy hypoxia type of scenario. That is one. So this may happen. But on the other hand, there are some patients who actually become hypoxic because of complications. That means because of the viral infection per se, which is a pneumonia. It is a viral pneumonia. Now, if that viral pneumonia is not improving, suppose it worsens, then it may lead to a fibrosis like a condition in the lung, which is known as interstitial fibrosis, which is a rare complication of a viral infection, which we have seen on a number of occasions in swine flu, H1N1 pneumonia as well. So similar pattern now we are observing here. In fact, right now we have got two such patients admitted in our ward itself. So we were trying to think what to do with them. So they require oxygen and they have changes on a CT scan which signify interstitial fibrosis. So this is a cause of concern because this may progress and cause further damage in the future. So one has to think why this is happening and what to do, whether a longer course of steroid is required or whatever. So this is some cause of concern in a small subset of patients.
Right, sir, you brought this out very well. We have also heard a lot about happy hypoxia, where young people actually are not even realizing that they are hypoxic and they are actually having the complications of COVID, sir. Right. So we have one more question which comes to us. It is slightly off track for you, sir, Dr. Mohan, sir. So this is a doctor who would like to know basically how would be the management of a lady who is pregnant with COVID. So basically, she is pregnant. Can she be given antimalarials, antivirals safely, and what would be the side effects on the baby? We have heard about PMIS syndrome very well in the children, but that is above for in an elder age group. So for the younger age group, for the pregnant and the newborns, she would like to know what is the impact, sir.
Well, the treatment of COVID-19 in pregnancy essentially remains the same as for other states, because actually speaking, there is no pharmacological therapy for COVID, first of all. So it is mostly supportive care. Pharmacology comes only in the form of, say, now you talk about antivirals. Antivirals, as such, do not really have a role in COVID infection. The only antiviral that does seem to have a small amount of role is the remdesivir, which has been tested in a small group of patients, and in moderate patients, it has been found to reduce the duration of hospital stay by a couple of days and viral clearance. So that is a very small subset in which remdesivir might be advocated. So, and the other antiviral, that is the favipiravir and the lopinavir and all these things, really have not stood the test of evidence base as of now to recommend them on a routine use in any situation as such. So they are not even part of the national guidelines. The guidelines by the Ministry of Health and Family Welfare, they are not part of the guidelines. I don't think they are part of the guidelines by the CDC or the WHO also as of now. Although, they are used on a case-to-case basis by many physicians across the country, but then that is their own personal judgment and their own perception of the situation at that point of time. So if you have to give any antiviral or anything, then it is better to first check the pharmacokinetics and the toxicity profile of that particular drug on the fetus and on the mother before we give that. Otherwise, even this anti-inflammatory drugs, see, steroids don't really have much of a problem. Steroids can be given safely for a couple of days, even in pregnancy, if required. Again, if required, so there are indications for that. The other IL-6 and other anti-inflammatory, anti-cytokine therapy like tocilizumab and the itolizumab again are required for a very selected group of patients. And also, one dose really does not have much of an effect, but one has to be cautious in this situation. Hence, the treatment essentially remains the same. If you have to give something very specific, then one will have to first be sure it is required and then check on the side effects and then administer with this. Even heparin can be given if really required. If the patient is hospitalized, critically ill, then heparin actually can be given, because at that point of time, your primary aim is to save the mother at that point of time. And a couple of doses of heparin really do not have much of a problem.
See,
Yeah,
as Dr. Mohan Sawa said very clearly in the last line, see, if the pregnant lady is there, so you have two lives to save. The fetus can be saved only when mother is saved. Okay? The fetus can be saved only when the mother is saved. Remember? I'm not discussing on 8 months or 9 months. Okay? Those kind of situation we are not seeing, and I hope nobody sees that. But the treatment, as Dr. Professor Mohan has said, first try to save the mother by the conventional regular treatment, and do not bother about the fetus in the first beginning. Mother is saved, fetus is the secondary part.
Right, sir. Right. Thank you for the clarification. So one more question for Mohan, sir. It has come for us from the audience. They would like to know should we give remdesivir to all the patients, or is it a particular subset of patients? And if we give, what is the ideal time to start? Same thing would be applied for steroids. When do we give steroids, and what would be the ideal time to start steroids, sir?
So coming to remdesivir first, no, absolutely, it is not supposed to be given to all the patients at all. It is not to be given to the mild patients at all. So the only indication that we have based on the NEGM article, which they did in a group of patients, they found in moderately ill patients, those who are hypoxic, who require oxygen, and in whom oxygen alone is not really working. So in that group of patients, probably it has some mild benefit by reducing the duration of symptom and the viral clearance from 15 days to down to 11 days. So a little bit of improvement in that was seen. It is not really very beneficial when it is given too late also, because by that time the cytokine storm has overtaken the patient. He may be critically ill, and it is not maybe recommended at that point of time. It may not work. So a small window when a patient is in moderate disease, semi-critical but not very critical, but he is not responding to the standard therapy of moderate illness at that point of time, and that may include steroids also. So suppose a patient has been given oxygen, he has been administered steroids, still he is not improving, then that might be the time to try remdesivir. As far as the dosage is concerned, trials were done for up to 10 days and also for 5 days. A comparison of 5 to 10 days was done, and it was found that even a 5-day course of remdesivir is equally efficient, equally efficacious. So our Indian guidelines recommend a 5-day course of remdesivir, that is 200 milligrams on one day and then 100 milligrams on the next 4 days. So total 5 days of therapy is given. As far as steroid is concerned, yes, we have some evidence of dexamethasone also, as was part of the recovery trial published in the NEGM, in which they found again dexamethasone did show benefit in improving mortality and time to viral clearance in patients of moderate disease. Again, those who are not improving on oxygen alone, when they were given dexamethasone, and then that had a bit of a benefit for. So that we have also kind of included in our treatment guidelines dexamethasone, or earlier we used to give hydrocortisone and even methylprednisolone, and we have continued with methylprednisolone to a dose of 500 milligram to 1 gram per day for about 3 to 5 days, and dexamethasone again 0.1 to 0.2 milligram per kg per day. That means somewhere between 4 to 8 milligram per day in these patients. Usually 3 to 5 days are sufficient, but it can go up to 7 to 10 days also. Usually there is no need to give anything beyond that, and there is really no evidence to give a patient a prolonged course of steroids after he is discharged home. So it is only to be given in hospital and then stop.
Right, sir. Thank you. Thank you so much, sir. So our next question is for Dr. Verma, sir. Sir, our audience would just like to know what is the incidence of cardiac or heart failure which is seen in COVID-19 patients, and what is the usual recovery method, or how do they actually recover out from the heart failure which is there, and what is the possible treatment which can be advised?
Ashish, the incidence of heart failure, which has been studied and been found to be as much as 23% of the patients.
Sir, my apologies for the interruption. I think you'll have to be a little louder because a few guests were complaining that your voice was a little lower. I'm sorry.
No. Why should we be sorry? This program is meant for the audience, and unless we are communicating to them, it doesn't serve the full purpose. See, as many as 23 to 24% of the patients of this COVID-19 developed heart failure. And that is very, very large number. And treatment of the heart failure in all these situations remains same, except very cautious use of ACE inhibitors and ARBs. As I mentioned, while answering the hypertension, please, if the patient is settled on ACE inhibitors or ARBs, please do not shift to them. But do not start ARBs and ACE inhibitors afresh. So that is the recommendation. Rest treatment for heart failure remains the standard treatment, diuretics, oxygen, and other therapies.
Right, sir. In continuation to that, we have another question which has come from the audience. They would like to know, is there any correlation between mortality and D-dimer and troponin levels?
See, those patients who have got high troponin levels or disturbed D-dimer levels, the mortality has been very, very high. As a matter of fact, majority of the patients who have entered the high intensive care units, their mortality chances are very, very high. And among those mortality patients, as I mentioned in the beginning of talk, if the world mortality has been 4 to 5%, incidentally in India is only about 2.5 to 3% only. And therefore, the studies said in Delhi has come down to 2.3%. If the patient has got pre-existing cardiovascular disease, the chances of mortality has been as much as 10.5 to 11.5%. If somebody has got coexistent diabetes mellitus, the same percentage has gone from 7.5 to 8.3%. While if somebody has got only hypertension, it was 6%. If you see the other spectrum, patients who have developed severe ARDS, understand this was the patient who are being affected. And of those patients who have developed severe ARDS, the hypertension amounted for 30% of the patients. In fact, if you see 100 patients, as many as 30% patients of hypertension could develop ARDS. For coronary heart disease, this ratio is about 8%, while for diabetes mellitus, it again goes from 19.1 to 19.9%. This means a pre-existing hypertension, a pre-existing diabetes mellitus, a very potential background things which could lead to development of a serious ARDS, and which could be potentially fatal. While patient having pre-existing coronary artery disease, this situation is only about 8 to 9%.
Right, sir. Thank you. Thank you for the elaborate answer. So our next question is to Dr. Mohan, sir. Sir, one of our audience members would like to know about the CT chest scoring values. How do you score it on mild, moderate, or severe? And is there any treatment for Lung fibrosis which occurs post-COVID.
Yeah, so actually, like we mentioned before, the CT scan is a reasonably important tool. Although the problem is it cannot be done on a majority of patients, and it need not be done in a majority of patients. So that message also should not go that every patient with COVID-19 requires a CT scan. That is not so. It is mostly a clinical and a microbiological diagnosis. Only in patients who are moderate to severely ill may undergo an X-ray, and usually an X-ray is good enough to show the peripheral, bilateral, peripheral kind of consolidation and the ground glass. Ground glass may be better seen on CT, and that may be useful, especially in those patients in whom, say, you are suspecting COVID clinically, but you are not getting a diagnosis microbiologically. For example, we had several patients, not several, but we had 3 or 4 patients in the last couple of weeks in our ward itself who came with symptoms of COVID, who came with, and the RT-PCR was done, which was negative. So we shifted the patient to our ward, and but we strongly suspected COVID. We got an X-ray done, and the X-ray was also showing the typical findings of corona infection. So we repeated a PCR actually. The second PCR was also negative, but still we kept the patient in a kind of a isolation side room because we knew that it is possible. We repeated for the third time, and the third time RT-PCR came out to be positive. So this happens, that is why RT-PCR may not be positive. Also, it is always a mixture of your clinical, radiological, and microbiology that you have to depend on because it all depends upon the technique by which you take the sample. As far as the CT is coming back to the CT, there are scoring systems available, and I think there are 2 or 3 Flischner societies also coming out with their own guidelines, and they are scoring them based on the number of zones, number of lobes, and the type of and the amount of area which is there. So I'm not really too much into the scoring system of the CT scan, but yes, they have found some correlation with the mortality and with the duration of the hospital stay along with the CT scan. And also they have found that there are some features which strongly, in a pandemic situation, they strongly suspect corona, and that means bilateral ground glass, bilateral peripheral consolidation. So these are some features which suggest a viral infection suggestive of a corona. So these are what is the radiological features, and we have to kind of consolidate that along with the other features that we have.
Right, sir. Thank you. So one of the questions which was also there was the fibrosis, how we can treat that.
Fibrosis.
So,
Oh,
right.
yeah, sorry. So you had a question about fibrosis. So now what is happening is that we are seeing more and more cases of post-COVID dyspnea, post-COVID fibrosis, post-COVID residual hypoxia coming up. And when we do now, when they are cured of COVID, then we can easily do a CT scan and all. And now we find that they have interstitial fibrosis, interstitial thickening, they have reticulations, they also have some residual ground glass also. Unfortunately, in most of them, we do not have a previous baseline X-ray or a CT scan because we don't do a CT scan at baseline in all patients. So, but if it is there, whether they were already having this beforehand, we don't know. Sometimes we have to go back into the history. If they were symptomatic with dyspnea, cough, shortness of breath even before corona, then probably they had some degree of lung damage even beforehand, which was not picked up. So some ILD may have been already there, but we cannot be sure. Now, in future, what to do is, for example, if there is any ground glass in the CT scan, then we probably can continue the steroid for some amount of time more and see, continue with the oxygen. And if there is more of interstitial fibrosis, so there is something like a fibrotic ILD type of picture, which may be like what we see in a UIP pattern, IPF pattern, or a fibrotic NSIP pattern. So these are the things in which now we are getting more patients. It is something new for us. We really don't know, but probably now what we are doing is we are trying to start these patients on antifibrotics early enough. The perfenadons, for example, we don't know whether it will work or not. We are trying to see. We are trying to do a kind of small study comparing this with no perfenadone to see over the next 3 to 6 months how they fare. But there is no treatment as of now, no guideline. There is no evidence for the actual management of post-COVID interstitial fibrosis. That is a relatively new entity, and we'll have to see how it pans out and how the treatment evolves in the future.
Right, sir. Just in continuation to that, I had a question. So, is there any specific way ventilation can be given, say a prone position ventilation or keeping a higher PEEP or something like that, which can actually avoid this?
Yeah, so ventilatory strategies are better defined, of course. Whether it will avoid this or not, that we cannot say, because that is meant for rapid improvement of the ARDS picture, because that is given when there is a ARDS picture. So improvement of the ARDS picture back. Whether it will prevent interstitial fibrosis, we can't say. But yes, the ventilatory strategies have to include prone position. Proning, of course, has to be early. It is before ventilation actually. Ideally, we should do it before we put a patient on a ventilator to try and avoid ventilation. So as soon as the patient becomes hypoxic, along with oxygen, our strategy is to immediately put the patient on a prone position, proning. So awake proning, that is what we do, and for several hours in a day. And we have found good results with that. And we have actually, there are studies to this effect as of now, even from our country, that it works. If it doesn't work, then of course we have to go for high flow nasal cannula. We have to go for the non-invasive ventilation. If that also doesn't work, then we have to go and intubate the patient and put him on a ventilator. The ventilatory strategies, again, are the typical strategies of the ARDS management: a low tidal volume, a bit of a high PEEP initially, and high FiO2. This is what we start off with. And then it is based on ARDS. There is the same kind of a thing that we do. And then we gradually try to decrease the FiO2, try to decrease the PEEP over a period of time, and we put him on pressure support and try to wean him off.
Right, sir. Thank you very much. So, this next question may not be related to therapy, but I would like to put it to Dr. Verma, sir, because he has actually shown us the mask. So, our audience would like to know what is the ideal mask or what should they actually wear to prevent a general public, not maybe the healthcare workers. Healthcare workers are very clear in this, sir.
See, the general public, by and large, should any fabric mask which is at least have got more than 2 layers. A single layer mask doesn't protect you too much. When a mask is being used, it should be snugly covering your nose, covering your cheeks, and covering your chin. It should not be loose mask. It should not be decorative mask. A lot of people are using only decorative mask. They should be tight. It should be tight from sides also. And it should have minimum 2 layers. And nowadays in India itself, we are making a lot of companies are manufacturing a mask with a membrane in between. So that could be very, very useful. We have got the RDO has recently approved a mask which can be washed with the membrane, washed for 18 times. It maintains the efficacy and safety. Now, when besides those things, using a mask, whenever you're going out in a public, when you're meeting a new person or a stranger or a person who you have not met for last 7-8 days, please do not hesitate using a mask. A lot of in Indian culture, there used to be old traditions, which I just want to revive with you. Ladies in our families never used to look at the senior males. They would look in different direction. When you're addressing and talking to somebody, not in this webinar, you can look at some other direction and talk so that the saliva from the mouth doesn't come out. And a mask protects you that more than 90-95%. That's why the name N95 started from there. So use a mask, which is a fabric mask. Only thing, it should be tightly on your nostrils, cheeks, and should cover the chin so that you do not receive and you do not give out in case you got this effect. And mask should not be kept in straight places. What I'm seeing and noticing nowadays, people are using a mask, then keeping on the table or any surface with their phone. So that surface could make the mask itself infected. So if you're not using a mask, put in your pocket. Otherwise, now one of the manufacturers was suggested by us, and he made a mask with a string, just like we have got glasses, and then the mask hangs on the chest from the neck. And when you're back in the public, use that and put it like this. So that would be a very, very useful thing. The mask doesn't become dirty. It's sticking on the chest, just like our glasses. I've got that. For an ordinary person, a simple single or double layer mask is more than enough. But if you're going to crowded places where you meet or interact with a lot of people who are strangers, who do not know whether they're carriers, whether they're actually infected by the corona, please do not hesitate in using a good quality linen fabric mask with a layer membrane in between. And do not use the mask for very long time. Don't, like our Indian habit. We do not dispose of our shirts, we don't dispose of our utensils, we don't dispose of our pants. Keep on using them. Mask is meant for a therapeutic use, a preventive use. Do not make it a permanent thing. Spend some money and get some good masks.
Right, sir. Thank you. Thank you so much, sir. So next question is for Dr. Mohan, sir. Sir, now we are approaching a season which is going to be slightly a different kind of a season where we might have cold, we might have from the rainy season, we'll be moving on. So is there any special precautions which have been taken for asthmatics, or do smokers or patients with COPD have a higher risk for COVID-19 symptoms, sir?
Well, so patients who are asthmatic, COPD, or those with any pre-existing lung disease, they are not at higher risk to develop COVID. So that can happen to anybody, depending also based on whatever their precautions and everything. But yes, once they develop the infection, then there may be a higher risk of increased severity of symptoms. There may be a higher risk of higher viral load. There may be a higher risk of more need of oxygen support and other supportive care in the hospital. So longer hospital stay, and there may be more severe disease, and there obviously may be more morbidity and mortality and more chances of complications, because already the lung is compromised, and that is why all these things are there. So that is why we keep saying that patients with already existing comorbidities are at slightly higher risk of complications from COVID. And that is the same case with the smokers. Whether they're heavy smokers, obviously they have distorted airways, they have compromised airways. Whether they're asthmatics, again they have constricted airways. So all of these are at higher risk of developing complications if they develop the infection.
Any specific advice for who are asthmatics, especially?
The specific advice is the same that we tell for everybody. The same principles of the avoiding any exposures, not to go out, do not interact as far as possible, keep your physical distancing, keep the hand hygiene, cough etiquettes. So basically, they should remain indoors as of now, especially if they are in a place which is a kind of a hotspot, or if they are in a place where there are a lot of cases in the neighborhood. So avoid markets. So all these things, avoid more walks with other people. So the same principles apply, and these are the standard precautions. So they should do everything possible not to get the infection. That is the bottom line.
Thank you, sir. So our next question is for Dr. Verma, sir. Sir, we have seen a lot of our healthcare workers also being affected by COVID. We have seen mortality in them. We have seen so many morbidities. So our doctors would like to know whether telemedicine can be practiced, and how do we ideally practice telemedicine for patients, especially?
See, this COVID has changed the whole world, and it will change the way we work, way we survive, way we intermingle. It is not affecting only the doctor and patients, it's affecting total society, and total social fabric is changed. We will see a lot of work from home, a lot of uh, dealing from home, and those pomp and show of big marriages, big social gathering, big conferences, big meetings, and big restaurants for waiting list of 2 and 3 hours, that all got dissipated. The air travel has got absolutely zero. So the same way, the relation between a doctor and patient will also obviously is being affected. Patients are scared to come to a doctor who is treating a COVID patient. Doctors are scared of treating patient, not knowing which of them could be a COVID patient. In fact, as a doctor, we faced a lot of very, very bad reaction from certain sectors of the society. Not all. One way where they were praising the courier warriors. On other ways, I know in Delhi, very much city of Delhi, the doctors are not allowed to the societies and group housing where they are living, saying that you might have seen a COVID patient, not even that you have seen a COVID patient. A lot of junior doctors, senior doctors face this music for several days. So those kind of situation will enter in our thinking and our psychology, and it will be indelible. You cannot wash away those things. So a telemedicine, a video conferencing would possibly become the thing of the day. And as the days will advance, as support from good companies like you, these things will perpetuate, and there's nothing wrong about that. There's nothing wrong about that. the load in the government hospitals, load in the big institutions like AIMS, load in the big hospitals like Safdarjung and other will be substantially reduced, but patient will get adequate amount of good treatment. Only thing is patient will be trying to develop either from treating from billing from the home, or there will be designated kiosk, video conferencing kiosk type of situation may come up. This is a situation where society has to develop, not as a doctor we will develop, but that is a thing which is going to come, which will be more practice than one-to-one interaction. Because doctors are, and doctors, nurses, and paramedics are at tremendous risk. If you see the crowds at the AIMS and Southern Hospital, you will be horrified. The kind of crowd that we attend, more than 18 to 20,000 OPD patients a day is a huge number, out of which how many are having this disease, we do not know. I must tell you, as a junior doctor, I'm not talking of myself or Dr. Professor Mohan, I'm talking about 20 years back when we were house officers or interns, 5 to 6% of our colleagues used to develop tuberculosis because at those times the hospitals were poor. The monies with the hospitals are very inadequate. Proper education was not there, and junior doctors, junior nurses were being affected from open patients with tuberculosis also. So similar situation has come now. The last which I read, more than 172 patients, senior doctors, have died in Italy alone. And as I mentioned earlier, part of our conversation today, that some senior doctors from Delhi have passed away. We have lost them. We're capable, competent, and good doctors. So this situation will change into telemedicine, video conferencing, video therapeutics, video diagnostics, and artificial intelligence is thing of day. We must accept it. We have to adopt to it, and we possibly are going to adopt to it. Thank you very much. I must say that I am absolutely delighted to hear from Professor Anand Mohan, and I was delighted to have very nice questions from you and the audience. And I'm really grateful to JB Chemicals, which are manufacturers of very good medicines, that they will continue to have this kind of interactive webinar in future also.
Right.
And your team of Arvind Kushwaha, Varun Agrawal, you Ashish Rana, and the Delhi team of Rachita Agrawal and Deepak and Ankur Bhardwaj, I'm really grateful, and I convey my thanks and on my behalf and Dr. Mohan's behalf both for JB Chemicals for this wonderful webinar. Thank you very much.
Right, sir. Thank you. Thank you so much, sir. Just if you could take a last question for Mohan, sir. Sir, could you take one more?
Yeah, sure.
So somebody has just asked, what is the role of colchicine, and for how many days can we face? How can we use tocilizumab, sir, to prevent a cytokine storm, sir? Just those two last questions, and then we can close. Sir.
So colchicine, as an antifibrotic or in any other way, as of now has no role, no proven role in this. So I wouldn't like to talk too much about that. We have never tried, and I don't think there is any evidence to that. The other was about tocilizumab.
Yes, sir. Yes, sir.
So tocilizumab, of course, as an anti-inflammatory therapy, has been tried, and we have also used it again for the same indications, similar indications as remdesivir. That is, patients who are moderate and going on to severe disease, that is semi-critical, pre-critical types, who are not improving with oxygen, not improving with steroids, and we find evidence of a cytokine storm in the form of raised acute phase reactants. And now, of course, if you have the facility of doing the IL-6 levels, and if it is raised, then you are further kind of justified in a way to give tocilizumab if it is available. So get that done, and then this can be used. And a single dose, usually about 160 milligrams or so, a single dose of IV infusion is given. But if it is a very severe disease, one can repeat the dose also and give it twice. So usually we give it once, but sometimes we have given it twice also. The only thing to take care is that it's a biological agent, it's an immunosuppressive therapy. So make sure that the patient does not have any underlying infection inside which may be flared up. For example, underlying tuberculosis should not be there. So it would be a good idea to do maybe a Montu or something to rule out underlying tuberculosis. And the reason for that is because, again, like I'm saying from my own personal experience, out of the couple of patients we have one patient right now in the ward who recovered from COVID, persistently hypoxic, and on CT scan, the patient had large right paratracheal node and a small cavity on the left upper lobe. And we tried to investigate whether it is a ILD or whether there is an infection going on. And it was a sputum gene expert only today turned out to be positive. and there was a necrotic node inside also. So it's a feature of tuberculosis, clear-cut tuberculosis. And why it happened, we don't know. But she received steroid for 2 to 3 weeks during a COVID period. So it is possible that these immunosuppressive therapy may flare up underlying hidden latent tuberculosis in a patient. So that should be ruled out before we give these strong biological agents.
Right, sir. Thank you. Thank you so much to both of you, sir, Dr. Verma, sir, and Dr. Mohan, sir. This has been an amazing session. We have answered quite a few questions which have been asked by our clinicians, though we may have missed some due to paucity of time. We thank you again for all this.
Thank you very much. Thank you.
Thank you so much, sir.
Thank you, sir.
Yeah.
And thank you to Arvind Kushwaha, as well as Varun Agrawal, Rachit Agrawal and his team, and you, Ashish, in particular. Thank you very much. If there anybody has got query, you have got addresses of Professor Anand Ohan. He is Professor and Head of Respiratory Medicine at AIMS Delhi, and you can always send a letter to him and ask him query from that, preferably not on phone, but other means.
Right, sir. Thank you so much, and we wish you a safe stay ahead in these times. And thank you for spending our time on a Sunday evening, sir. Thank you so much.
Thank you
so
all
much.
of you. Thank you, Dr.
Thank-
Verma, also for inviting me. It's a very nice session. Thank you.
Thank you so much, sir. Thank you, both of you, sir. It was wonderful session. We are sure all the audiences would have immensely benefited out of it. Thank you so much, sir.
Thanks very much. Good night,
Thank you
everybody.
from my end as well, sir. We can't thank you enough, but yeah, thank you so much for taking
You
time.
are very, very good, and the Zoom was very, very good. Keep it up. My best
Thank you,
wishes.
sir.
All right.
And best wishes to Arvind Kushwaha also.
Yes, sir. We'll continue to do such programs further, sir.
All and his team really.
Thank you,
worked
sir. Thank you.
well. Bye-bye. Bye-bye. Bye-bye.
Bye-bye. Okay.
Jay, can we close the session, please?